Why is it that the cell triggers on, and why is it not shutting off? Basically, it's initiation from DNA mutation. So things that can, of course, increase the risk of DNA mutation are things like radiation damage, chemical exposure, infections such as viruses can also affect DNA mutation. Okay? We know that promotion is rapid division of tumor. The cancer cells, because they increase so rapidly, they tend to also cause angiogenesis, which means that they increase the amount of blood supply to itself. Okay? And it sends out hormonal regulators to increase the actual growth of the actual blood vessels around it. That's why when you touch cancer areas, you see a lot of bleeding. It's very difficult to treat these people at times because you just can't cut out all the cancer because you get so much hemorrhaging. The person literally starts hemorrhaging to death on you. What we actually have found that works very well for these kind of cancer patients is that we put beads in it, into the blood vessels that are going to it, and we infarct it. Okay? And then we debulk the cancer after that. So we go in there with radiology, and we sedate the patients for them as well. And the radiologist will then look at the vascular supply of the tumor and will then throw beads or throw in little metallic pieces into it that causes the coagulation to take place and then kills the blood supply to it. Now you have to basically remove that cancer fairly quickly after that, maybe in about 4 or 5 days, because you get active necrosis. And that necrosis can, of course, cause problems to your kidneys and all the other things. So it's part of the treatment protocol. Progression for cancer cells is that you get aggressive growth and metastasis. Many of the cancers that you see are initially not discoverable because the liver processes many of the products of these cancer cells. So it's not until you bypass the liver where you metastatic beyond the liver and you get into the lungs where the person becomes symptomatic and they get skin rashes and sorts of other symptoms that normally when they're inside the abdomen, like colon cancers, you don't really see. The types of DNA mutations, you can get point mutations, you can have alterations in substitutions, you can get mutations through deletion, and you can have mutations through addition as well. And each one of those causes problems later on with protein production or other forms of other kinds of compounds besides proteins that are not produced properly. You also know that telomerases are very important enzymes. They're very important proteins that hold the DNA tightly. And for some reason in cancer patients, these telomerase enzymes allow for unlimited replication to take place. So you get repetitive action that quickly these new cancer cell lines. The tumor-induced angiogenesis, which I was just talking about, is the actual tumor cell increases its blood supply and steals the blood supply from other areas, and of course it makes it much more vascular as a consequence. Normal progression of epithelial cancers is that it shows dysplasia, which means the cells become abnormally larger than it used to, and then it begins to invade locally, which is called an in situ neoplasm. If you remove that section completely at that point, that person is cured of the disease. Okay, if you can pick it up that early, then you basically take care of that person. They don't have a problem. This is why we do colonoscopies on everybody. We're looking for polyps, and there's different kinds of polyps. There's pedunculated polyps and C-cell polyps. If you remove the polyp, you're basically removing the in situ neoplasm. We also see this in cervical cancers where the viruses affect and attack cervical. That's why we do pap smears on people. We're looking for these kind of neoplasms. There's dysplasia. Dysplasia is the first stage of eventual conversion into an invasive neoplasm. So that's why we end up doing hysterectomies on individuals, or what we call cone biopsies and different treatments that we have available. Obesity also apparently increases the risk for developing cancer. We're thinking that it's mostly due to increase in free fatty acids and increase in resistance. It increases insulin resistance in these individuals, and elevations in insulin may actually increase the risk of target cells develop, decreasing apoptosis and increasing cell proliferation, which increases the development of tumor development. So we do know that obesity does increase the risk of developing cancer. The body mass index and risk of cancer deaths, it shows you here as the body mass index increases, colorectal cancer and esophageal cancer increases dramatically. Even breast cancer increases dramatically with increasing weight. That doesn't mean that the person who's thin and healthy looking can't get cancer. That's not true. It just means that statistically, people that are morbidly obese have a higher risk of developing it. But does not mean that the rest of us are not at risk. What you see with pathogenesis with metastatic disease is that this disease goes from in situ, eventually goes into the lymph system. The lymph system will try to remove the cancer cells, and it does it effectively most of the time. But once it gets into the bloodstream, if it's inside your peritoneal cavity, it goes to the liver, where the liver tries to remove the cancer. If it can't, then it bypasses the liver, and then it gets into the rest of the system, usually going to the lung. And there's different kinds of cancers that will go to different parts. Prostate cancer is usually found in very high percentages in bone when we first diagnose it. If it's not being picked up by doing PSA tests, PSA tests. And you also will get breast cancer that will be metastatic to the bone as well. So GI-wise, you tend to see colon cancers will go to the lung, usually preferentially, after it bypasses and becomes metastatic after the liver. Normal cancer treatment is surgical excision and debulking. That was the only way we used to do it in the 1910s and 1920s. People would go in there and just cut. The problem is you never get rid of the cancer because it's a cellular level. So unless you get lucky and get all the cells, you don't get rid of the cancer. So the next thought process, well, we know that cancer cells are rapidly growing cells. So we attack those rapidly growing cells with toxins of one type or the other, then we can hopefully kill those cells at a more rapid rate than we kill the normal cells. Okay, so things that we found that can do that are radiation. Okay, so radiation became a mainstay of therapy, and also another thing called chemotherapy. Chemotherapy is basically taken from barks of trees, and a lot of them are fungal components. And you have to ask yourself why, because those kinds of organisms are producing these things to kill rapidly growing organisms that will attack it. So if you think about a bark of a tree that's constantly being attacked by bacteria in this environment, if it could produce a certain kind of a toxin that could kill rapidly growing bacteria, that would give it a certain degree of survival improvement than other organisms. So that's where you find these kind of stuff, and that's where we're looking for it constantly. Okay, we're looking for biodiverse trees, trees that look a little bit different. You'll see people will actually remove the bark and then test it to see if it can be used as a chemotherapeutic agent. The other organisms that fight a lot of bacteria and a lot of other kinds of rapidly growing cells are funguses as well. So funguses have a very good chemical armamentarium, and as a consequence, we copy their stuff and use it as well for chemotherapy drugs. Okay? The bad thing with chemotherapy is it kills all fast-growing cells. Okay, not only tumor cells. So in a sense, you're killing the individual partly, so they get severe nausea, vomiting, because the GI lining is rapidly growing cells. So they can get severe diarrhea, nausea, vomiting from it as well. So chemo is difficult to say the least. We are now using other things called immunostimulants, where things like using interleukins, which are activating the white cells, which then can hunt down the tumor cells and kill them. We know that some people actually can reverse. I'll never forget this in my life. I had a patient when I was an intern. First saw this individual, had metastatic cancer. Everybody gave her 6 months to live. And we had 3 CT scans. So it's not like it was just one that somebody made an error and get. We had 3 CT scans showing the disease process. She actually decided, you know what, I'm not going to go through chemotherapy. I'm going to do something completely different. Okay? Which was, okay, whatever it's going to be. So I won't tell you what it was, but The person came back about 6 months later for a repeat CT scan, which we thought she should be dead, and she had nothing. It was all gone. So, and that is, people do have histories of spontaneous recovery from cancers. It's not very common, but it does happen. We don't know exactly what the mechanism is. Okay, when we sat and talked to her, she had these 3 modalities that she used. One was high doses of vitamins. The other one was prayer. And there was one other thing that she called the holistic dreaming, which was strange to me, but whatever, it worked for her. So, and you can't say no when you see something that so obviously improved, versus all our chemotherapy drugs weren't helping many people at the time. The new chemos are much better. They're less individually. They're better in the sense that we know what works for what different cancers. The really things that are really coming important is now immunotherapy. We are actually beginning to learn enough about the immune system that we can actually produce antibodies to a certain disease and attack it using immunotherapy. There's one cancer called, we'll talk about it, it's called multiple myeloma. Okay? And if you look at multiple myeloma, on the surface of it, every single cell that has multiple myeloma has a clearly identifiable glycoprotein molecule on it. Okay? And they're actually now producing an antibody that's now going to go into study, that it binds to that cell only, and that antibody then brings the white cells to it and kills that cell. So there's a possibility now, not theoretical, now it's possible, they've done it on animals, that you can perfectly cure somebody of this disease, which is right now a very bad way to die. It's rare. So hopefully, if we can get those kind of therapies in place and we can be a lot more selective and knock out only the tumor cells, then we don't have to give the wide spectrum chemo that really does all the damage that it does. That's what's called monoclonal antibody therapy, to tumor-specific antigen. That's what that was just talking about. Cancer surgery can be radical. We used to do so much radical resection that a lot of the surrounding structures were sacrificed. The goal was basically cure. Unfortunately, a lot of times we didn't, and we just caused havoc in that individual. A lot of the new procedures are more minimizing. We're not doing as much radical resection. When I was first training, almost everybody had a mastectomy, period. Nobody had any kind of just small little resection. Everybody would get a mastectomy, which was very hard on women. It was unnecessary, really. Debulking basically reduces the tumor load. Structures can be preserved, and the goal is palliative. Okay. Radiation for cancer induces a vasculitis and cell-killing mutations, rapidly dividing cells. And here's where it becomes a concern for us. It causes a lot of scarring of tissue. Okay? If somebody tells you that they just received radiation therapy to their neck and head, you really have to be concerned. Okay? You have to do a really proper airway examination in that individual. Because what you'll find is that you have so much scarring that when you try to move the larynx, you can't even move it. Okay? These people are very difficult to intubate, and they can be also very difficult to ventilate. Okay, so you've got to be really, really careful with these people. There's also your traditional chemotherapy agents, such as your alkylating agents. You also have your antimetabolites that are also available as well. I'm not going to go into all the specifics. There's also antibiotics, which is the fungal agents that I was talking about, bleomycin, mitromycin. Where it says mycin, that's made from a fungus. Okay? Nitrosoureas also interfere with DNA synthesis. There's enzymes like L-asparaginase, which interferes with the protein synthesis. Then you have what I was talking about before, plant alkaloids. These are things that are found on the tree barks, such as vincristine and vinblastin, and they basically disrupt the mitotic cell division and basically kill rapidly growing cells very effectively. Plant alkaloids is something that a lot of people are really looking into because it seems to be another potential area of a lot of hope, and we'll see how it goes with that part. Toxicity of traditional chemotherapy is the alkylating agents cause bone marrow suppression. It attacks the kidney as well as the lungs. which is a small capillary microvasculature. The anti-metabolites also cause bone marrow suppression. So a lot of these people, almost all these drugs cause bone marrow suppression because those are rapidly growing cells and are very similar to cancer cells. The plant alkaloids also cause peripheral and autonomic nervous system dysfunction. Antibiotics, such as cause bone marrow suppression, stomatitis. Bleomycin specifically is very dangerous for us in the sense that if you expose that person to oxygen, they can get severe pulmonary fibrosis to develop. So be very careful with those individuals. The daunorubicin attacks the heart, on the other hand, and you've got to always ask if they had a MUGA test, which is a multi-uptake gated exam to look at the EF of the heart after you give somebody daunorubicin or adriamycin. The nitrous also cause bone marrow suppression, and the L-asparaginase causes hepatic failure in some individuals. Antigen-modified chemotherapy means that you take a person and you find that certain kinds of T cells are sensitized to the cancer, and those T cells then activate and kill the cancer cells. Now, the answer is, why are T cells so important? Okay, there's different kinds of T cells. There's T helper cells, and there's what's called natural killer cells. They're very important in finding things that have a slightly different cell structure in the cell wall, and then attacks those specifically. So it's very specific to the actual antigen that you're trying to kill. Okay, we're finding that this is where I think cancer therapy is eventually going to go. You're going to take a cancer cell that you have for that individual, you're going to grow it out, look at the microstructure of the anatomical wall of it, and then you're going to be able to pick out which T cell line that you have that will attack it, and then infuse it into the individual, and that T cell line will then kill that cancer and get rid of it. That's using our own immune system or this immune system that we already have and enhancing it to cause that activity. Now, what other things can you also do to enhance the immune system? And that's vitamins, especially vitamin C. Vitamin C in high doses can also help considerably in the white cell strength and ability to protect you from infection. So it has also an anti-mutagenic capability as well. The cytotoxic T cell chemotherapy is, again, what I was just talking about. You take expanded T cells and you inject it into the patient, and these things identify and kill the actual cancer. And then you have immunostimulant therapy. We know that certain kinds of drugs that we can give individuals can actually increase the person's endogenous immune system. And unfortunately, for most people that get cancer, what's the first thing they develop? You can almost pick out somebody who has cancer from a good distance. You can tell them that they're sick. They start losing weight. If you ever talk to a patient, they say to you, "Oh, I've lost 30 pounds." And you ask them, "Why do you lose 30 pounds? Have you tried?" Nope. That's a bad sign. Anybody who tells you that they lost 30 pounds for no reason usually has cancer. Okay? A dog can actually smell the cancer in an individual. Okay? If you have dogs that sniff cancers, they can actually pick it up. Okay? What's happening is those individuals are developing what's called catabolism. Okay? They get what's called a catabolic enzyme that's being produced in there by the cancer cell that begins to break down the nutrition. And that's important for the cancer cell. Why? It immunosuppresses you. Okay? If you knock out the nutrition, immunosuppression sets in and the cancer is very happy. Okay? The more immunosuppressed you are, the more the cancer cells are able to survive. Okay? So that's one of the things that they do to try to keep themselves in existence, at least for a while. Some kinds of cancers are not only invading next door to each other and then they roll off and go on down the bloodstream and go attack another area, but they also release different kinds of compounds into the bloodstream, okay, and into the lymphatic system. These can cause tumor necrosis, inflammation, and they can produce what's called endogenous pyrogens, which causes people to get high fevers. Okay, it also will induce anorexia and weight loss because of the tumor necrosis factor that's being released. Hematological derangements is also present because it will attack the bone marrow, causes anemia, pancytopenia, and DIC. So paraneoplastic syndromes are usually certain kinds of cancers that tend to release these kind of pyrogens and endogenous compounds into the bloodstream. You can also get myasthenic-like syndromes where the person will become weaker. Usually it's not like myasthenia gravis, it's more like myasthenic, where it actually attacks the actual muscle partly, but also the actual neuromuscular junction, but not to the degree of myasthenia gravis. You may also get hypercalcemia from bone metastasis and increase in parathyroid hormone production. And you may also get an increase in urate, potassium, and phosphorus because the cells lysing from the rapid expansion of these cells. Adrenal insufficiency may also develop, and you get metastatic replacement of the gland by this. And you get renal dysfunction from all these cells that produce what's called antigen-antibody complexes. You can get ureteral obstruction and hyperuricemia developing. And you can get interstitial fibrosis sometimes when you treat these individuals with things like bleomycin. Ectopic hormone production, things like adrenocorticotropic hormone from small cell cancers, medullary cancers, thyroid, thymoma, carcinoid on beta islet cells, which is pancreatic tumors, develop Cushing's-like syndrome, where you can see the kind of round face, the moon face in an individual. You get the buffalo hump in the person's back of their back, okay, and it shows that they have elevations in ACTH. I'm not going to go into all this because I think it's just part of your endocrinology lecture, so I'm going to just keep skipping through this. But what you see is an activation, but not from this, not from the actual pituitary, but it's actually being released by the cancer cells, which increases the production of cortisol by the adrenal cortex. The other things that you can get from small cell pancreas and lymphomas is antidiuretic hormone that's also being released. Remember, when you look at normal antidiuretic hormone, that's your posterior pituitary, and that helps maintain fluid content in you. In these cancers, you actually can get hypersecretion. And when you look at the actual posterior pituitary, it's producing almost zero ADH in that situation. But you get a syndrome of inappropriate antidiuretic hormone, and you get increased retention of fluids in these individuals. Parathormone also can be from other kinds of cancers, such as renal, squamous, which is the lung cancer, pancreatic, ovarian cancer, and leads to what's called hyperparathyroidism. You can also get a release of thyrocalcitonin from medullary cancers of the thyroid, which leads to severe forms of hypocalcemia. The reason I'm making you paying this attention to is you've got to check your ionized calcium levels when you're taking care of neoplastic disease syndrome patients. Okay, and patients that have paraneoplastic syndrome, you've got to be really aware of it. Okay, and there's all these other ones that I'm not going to go into. Just know that there's many different kinds of ectopic hormones that are being released by these kinds of cancers. One of the things that the small cell cancers will produce is hyperpigmentation from melatonin production being increased by melatonin stimulating hormone from small cell cancers. So sometimes you'll see hyperpigmentation, which indicates to you that the person already has underlying pulmonary cancers in that individual. They look like they're tanned. It sort of jumps out at you. You also can have cardiac complications from medications that we try to treat these people with, which is doxorubicin and daunorubicin. These cause cardiac effusions and tamponade. Sometimes you'll get cancer invasions inside the heart itself, and you can get heart rupture when you give these patients these anti-carcinogenic drugs. You can also get what's called superior vena cava obstruction, which is called pumpkin man's head. Okay? You see the person's head will become hugely enlarged by the superior vena cava, and that becomes a very difficult person to intubate. They usually die of cerebral edema. It's not a good way to die. It's very slow and very uncomfortable. You can also have spinal cord compression from different kinds of cancer, which leads to increases ICP and cause other problems. All right, so let's look at individual cancers. Lung cancer is really the #1 cause of cancer death. It's found, especially in overseas. It's found in very high concentrations now, not so much in the United States like they used to. When I was coming up into the ranks, we had a lot of people dying from lung cancer. I almost don't see lung cancer anymore in the United States. Okay. Well, it's really interesting. This is how distorted people can become. Philip Morris, which is one of the tobacco companies in Czechoslovakia, was going to get taxed. I just read this about 2 weeks ago. I find this kind of very cynical. The reason they were going to be taxed is because the government said that they were increasing the cost of health care. Philip Morris did a study in that country which showed that their actual health care costs are reduced by smoking excessively. And the reason being is because they said they helped kill the person off by the time the age of 60 before they got into retirement age, and as a consequence it was more beneficial for their economy for letting them smoke. That's called being cynical. Okay? So if you do smoke, you need to stop. Don't keep feeding these bastards their money. Okay? I just personally hate smoking. I've seen my grandfather die of it, so I just don't like it. Okay? Especially something that's preventable. And people in the rest of the world are still being told that it's cost effective because you die at 60. Well, they're right. You know, if you die at 60, 65, you don't have to have health care services after that. And you don't have to provide them with chemotherapy because it doesn't work anyway, so what the heck. So really, the best way to avoid lung cancer is don't smoke. Okay? There's over 154 or more than that carcinogens in smoking. Okay? Most of it is from fungal components because of the way tobacco is processed. So basically, if you're smoking, you're basically smoking fungus all day. And that's why you get the eventual cancer development. Does that mean that everybody develops cancer? No. I've had an 89-year-old lady who was told by one of my other resident friends to stop smoking. She'd been smoking 2 packs a day for 72 years. I told her, don't worry, keep smoking. Her lungs were absolutely perfect on chest x-ray. She had genetics that were basically perfect for smoking. But that's less than 1% of the smokers. If you have on the other end of it what's called alpha antitrypsin deficiency, you develop emphysema and develop cancer at very high, very rapid rates, as low as in your 20s or 30s. I've had people get lung cancer at 25 or 35. So just because most people don't develop cancer until they're 60 doesn't mean that you can smoke till you're 40 and everything's fine. You need to stop if you're doing that now. You might be one of those unlucky ones in your 30s who develop this stuff. Lung cancer can be broken down into different kinds. The squamous cell, which is originated from the bronchus, they tend to be slow growing. They tend sometimes to become releasing of parathyroid hormone and cause bone mets to develop, so you get hypercalcemia in these individuals. This is what I show my kids if they consider smoking. The way I was taught not to smoke was one day I saw my grandfather smoking, and my father saw me saying, wow, it's kind of cool. Can I smoke, Dad? And I was like 6 years old. So my dad bought me a cigar. It's a big cigar. He said, oh, just smoke this. So I took the smoke and I inhaled this deeply. I must have done about 3 or 4 puffs. And then I started vomiting for the next 3 days. And that pretty much killed me of ever smoking again. So it was interesting kind of therapy, to say the least. Lung cancer is then other forms of adenocarcinoma, which tends to be more peripheral. It invades into the pleura and it causes hypercoagulability. This is what you see down here. This is a cancer. Of course, this person either has died or the lung has been resected from this. Most likely just resected from surgery. You can see how it begins to invade. It begins to completely consume the whole lung. It causes lymphatic invasion, which is small cell. Small cell is nasty because it's highly metastatic. By the time you find small cell, it's already all over the place. So it's very difficult to treat. A lot of times you get what's called SIADH, which is syndrome of inappropriate antidiuretic hormone, or release from too much levels of ADH produced by the small cell cancer. The other thing, it also acts as an attacker of calcium channel blockers, calcium channels, inducing what's called an Eden-Lambert syndrome. The Cushing syndrome is also because of these are paraneoplastic cells, and they produce increased levels of ACTH, and as a consequence, you increase levels of cortisol in these individuals. Then you have large cell. They tend to be found more in the periphery of the lung. They also metastasize early, and the unfortunate part about this large cell is that it tends to metastasize to the brain. So most of these people usually come in with brain cancers. They also will have gynecomastia from production of estrogen, and may also develop gonadotropin production, which is galactorrhea. The next set of cancers are colorectal cancers. It's the second leading cause of cancer death. That's why it's recommended that you have a colonoscopy by the time you're age 50, and then you get serial colonoscopies after that. About 99% of them are due to adenocarcinomas, and that means they have local infiltration before they become metastatic. So in other words, you can cure these if you get to it early. So you should have your exam at 50. If you're a high-risk individual, then you need to talk to somebody, which means that you have a family history of developing colorectal cancer. Then you also should talk to your physician about that. There's different populations that have very high risk for developing colorectal cancer. The highest risk for colorectal cancer is where in the world? Mexico. So eating hot foods must not be good for you. Okay? So they actually have the highest incidence of colorectal cancers in the world. As for stomach cancers, somebody said Asians. Asians have high incidence of stomach cancers. We think that's related to the fish that they're eating that's raw. So most likely it's a parasitic infection that's attacking the GI lining and eventually forms stomach cancers. If you listen to, I have some friends of mine that were from Japan, and they were always wondering why we would give people propofol for sedation. They still think we're a bunch of wimps. Sorry, you know what? If I have to do an upper endoscopy on me or a colonoscopy, thank you for my propofol. I want to be comfortable. In Japan, they actually do the endoscopes awake. And they do the actual upper endoscopies awake. No sedation. Brutal. I don't think that would be very pleasant. But they have such a high problem that they have to screen people regularly for upper endoscopies. I think they do it at age 35 or 40. They start looking just to prevent the actual full-blown stomach cancers. Adenocarcinomas will form from polyps, and then they form what's called apple core lesions. And that's pretty difficult for a student to understand what an apple core lesion is. What you do is when you do a test such as a barium study, they give you the dye to drink, and then they shoot the x-ray. And what the x-ray shows is it looks like this. And you see it widening out in here. And that's the apple core lesion. Okay? And the reason being is because a tumor, and drawn red, is here. It's invading inwards. So it gives you this apple core kind of lesion. Okay, and that's what this is right here. What they've done in this picture is they cut the colon in half and peeled it open to show you what the surface looks like. Okay? The reason that these people present, if you're presenting really late, is they start developing changes in their stool habits, where instead of having a normal sized caliber stool, their stool becomes very narrowed. Okay? Which indicates that you have this kind of compression that's coming outside, and your stool changes in character. If you wait too long, the cancer will obstruct, and that person will actually die unless you actually do a diverting colostomy and you remove that lesion at that point. Okay. Sometimes you'll hear that you're going to do a palliative diverting colostomy, which means that somebody who has widely metastatic disease can't really have it resected, but to leaving the cancer that will eventually obstruct, and the person will die from the obstruction, which is a horrible way to die. Instead, they actually divert the colostomy and then they try to debulk the cancer, and then try to person chemotherapy and radiation therapy to try to get rid of it. When you do these kind of cases, you got to watch for bowel preps. You can lose a lot of volume. Transfusion also apparently decreases survival because it actually acts like an immunosuppressant. Radiation to the abdomen increases blood loss. because you can get a lot of adhesions and neovascularization that takes place. So also be aware of that as well when you're taking care of these patients. And what we're doing now is we're actually hitting them with radiation usually before we debulk, if it's a large tumor, to try to reduce the tumor size. Second leading cause of death in men is prostate cancer after lung cancer. We do PSA screening to pick it up. The problem with PSA screening is it's too sensitive. Now we're picking up cancers that are not even symptomatic or not even a problem. And prostate cancer can be really slow growing. So if you have an elevated PSA in an 85-year-old, should you really do anything? My answer to that is most likely not. You're going to do more damage to trying to put that person to sleep into removing their prostate than just leaving the disease be. Because that person's going to die of something in the next 5 or 6 years. So what are you going to do? But you could actually kill them in the process of doing the surgery. Some of these symptoms will cause the urethra to close down, and as a consequence, TURP therapy is considered. Cryotherapy, radiation treatment as well. Hormone therapy, which means that they remove both testicles in that individual and give them estrogen therapy. Also helps. Chemotherapy has been also indicated, and now we're actually putting in radiation beads into prostates. And you're going to be doing a lot of those. Okay? When we do these, we have to put them under general anesthesia because the way radiation beads are put in is with ultrasonography to see what's going on, so the patient cannot move one bit while they're doing it. If you move when they're doing the procedure, then the procedure has to be restarted, and it's a nightmare. So you don't want to do that. Okay? So these patients are usually intubated, muscle relaxed, and not allowed to move when they're doing the procedure. And also, because the procedure goes from 0 to when they put the probe inside the rectum, it causes a lot of stimulation. Patients will then move away, or when they hit the needle into the skin, into the not the peritoneum, but the area where the rectum is at, with the needles to put in the actual radiation seeds, people will move away. That's why you have to keep them deep, because they go from no stimulation to maximal stimulation very quickly. Breast cancer, unfortunately, the lifetime risk of developing breast cancer is about 12%. There's a 3% risk of death, 70% cure rate, which is pretty impressive. Wish it was 100%, but it's still pretty impressive that you can actually cure this kind of cancer. Unfortunately, with breast cancer, if you don't catch it early, it goes to the bones, which is pretty not a nice way to go. Axillary dissection causes risks for developing lymphedema, which is always a concern for us because we have to put IVs in individuals. If you have somebody with bilateral axillary node dissections, you have to put the IV in the foot, or consider putting an IV in their hand just long enough to put them to sleep and then put a central line, okay? Which is okay to do as long as you don't become infiltrated. Infiltrated lines is where you become a problem. As long as you're staying in the IV, it's okay, but you can't take the risk of keeping an IV for a long period of time in that individual because almost all IVs eventually infiltrate. So you got to avoid that problem. You see that also they'll inject what's called isosulfan blue, which will cause a decrease in pulse oximetry. Don't freak out. It doesn't mean that anything's happening. It just means that they injected the dye. Treatments include tamoxifen and raloxifene, which are a lot of women complain of menopausal symptoms, and it also increases the risk of developing DVTs. Breast cancer chemotherapy sometimes can go all the way down to full bone marrow suppression, and you can actually give them radiation, which of course can be causing problems with lungs, pulmonary fibrosis, and cardiac complications as well. Head and neck cancers, thyroid cancers, the risk of recurrent laryngeal cancers. Airway evaluation is always critical because you want to make sure that the laryngeal nerve is not knocked out. One of the things that we show you to do is that we monitor for recurrent laryngeal nerve using a specialized endotracheal tube. When you put the endotracheal tube in place, you've got to put the actual wires that are on the endotracheal tube right against the vocal cord so you get a good response when they're working with the stuff. So you have to do it. We usually do it with a glide scope now so we can actually see what you're doing. So esophageal cancer is in all kinds of head and neck cancers, almost always related to smoking and alcohol. Okay, smoking is bad enough, but if you drink and you smoke, bad risk. Okay, we had one guy that came in that was 25 years old that was smoking, and he developed leukoplakia in his mouth. And immediately people said, stop smoking. He stopped smoking, the leukoplakia persisted, which we found 3 or 4 months later that now the leukoplakia was looking like a little bit like it was developing the squamous cell carcinoma. So at that point we started asking more questions. What are you doing? Are you drinking all the time? The typical question is, how much are you drinking a day? I don't drink anything a day. Okay, strange. Okay, you don't drink at all, never. Don't touch the stuff, I don't like it. So somebody that was actually opened his mouth, looked in, and we noticed something peculiar. The guy smelled like alcohol. Okay, so I asked him again, so what do you use as mouthwash? And he uses Scope. Okay, and Scope has alcohol in it. And he was using it 20 times a day. He was almost using it like constantly in his mouth because he didn't like the way his mouth smelled from the smoking. So he was basically like drinking, vodka all day long. Okay, and that was causing leukoplakia. As soon as he stopped using the Scope, the leukoplakia went away. Okay, so if you're using mouthwashes, use mouthwashes that don't have alcohol in them because they begin to damage the cells in your mouth, especially if you're smoking. So another hint if people who smoke. Pancreatic cancer is the 4th most common cause of cancer death. Surgical resection involves a huge procedure for this called Whipple. Whipple procedure basically removes the head of the pancreas, removes the duodenum, and replaces the actual biliary duct and reanastomoses it. It's a major, major procedure with a lot of complications. If you really have more than usually the cancer is right at the head of the pancreas, but if the actual cancer spreads into the rest of the body of the pancreas, then you have to do what's called a total pancreatectomy, which causes a lot of problems because you get malabsorption, you get diabetes, and you're 5%, you have 5% 5-year survival. So that's not very good. Okay? That's a very big operation. I've only seen 2 of them done, and they were both nightmares. We put in almost 25 liters of crystalloids in both of them, in each one, okay? Plus blood and everything else. Because when you go back all the way to the retroperitoneum and get into that area, you're denuding this peritoneal surface. And when you touch the pancreas, it releases all these all these enzymes that break down everything. So it causes very big problems for you as for third spacing. There's, of course, palliative procedures that we see down here all the time, things such as biliary diversions. And sometimes we're called down to radiology to help with them. They actually will put in a biliary stent, radiation chemotherapy, and then we also, for pain-wise, these are very painful cancers, we'll do a celiac plexus block, and we do them under CT-guided therapy to do that. Bone cancers, things like multiple myeloma, I'll come back to this at another time. It's a single cloned plasma cell. We'll talk about this in immunotherapy a little bit later. It secretes immunoglobulins, which then causes renal failure in these individuals from the Benz-Jones proteins that are being released. Multiple myeloma is basically a plasma cell disorder where you get overstimulation of these kind of special cell lines. As a consequence, it actually infiltrates into the actual bone and causes necrosis. These people have multiple sites of injury and causes a lot of pain. As you can see, this is another kind of cancer called an osteosarcoma, also called Ewing sarcoma. The only way to treat this is resection. This is why you see this here. This is an amputation that you'll do on these individuals. Sad, usually it happens in young people in their teenage years. And also we'll see things we'll call chondrosarcomas, which is the actual here, which is the cartilage. This one is an osteosarcoma here, which is originating from the bone itself. Then you have lymphomas. Lymphomas are Hodgkin's are induced by Epstein-Barr virus activation. And you have things like leukemias. There's different kinds. You have the acute lymphoblastic leukemia, which is ALL. Or you have the CLL, which is chronic lymphocytic leukemia. You also have adult T-cell leukemias, myeloid leukemias, and chronic myeloid leukemias. All those are bad news. They have a higher cancer rate they're not, but they highly mortality rate with those. And chemotherapy is the mainstay of therapy for these, as well as bone transplantation, which I've seen those done. I've taken care of those people. They're fairly complicated. They get all the immunosuppression you can imagine for prolonged periods of time, 30 days, and they're put into almost like a reverse isolation to protect them until their bone marrow is then replaced by usually another donor or by actually cleaning their own cells beforehand. So sometimes it works, sometimes it doesn't. Pretty expensive to say the least, and mortality rate's very, very high. Okie doke, we'll stop there, give you guys a 10-minute break, and then we'll finish up on the immunology next.